Hey, if you just give me 1 minute while I wait for some of these slides to load on the system. It's just taking a little while, and then we'll get right started into it. Okay, so we will get started, and I'm just going to introduce myself. My name is Vanessa Nara. For most of you, I have had some of you during the AP or SGT classes last year, if you do remember me. I am one of your anatomy tutors, and I will be seeing you tomorrow for that SGT that you have in renal. The lead person for this component is Dr. Karuna, but she's away at the moment, and she'll be filling in the rest of the other classes to follow, okay? So for today's session, I'm just going to show you the session plan for today. We do have quite a few concepts to go over, okay? So as you can see, we'll be going over some of the anatomy practical SGTs to remind you the expectations of them and to also remind you of some of the useful resources that we have. I'll then go over the overview of the urinary system, and we'll be looking at the kidneys, ureters, bladder, and urethra. All of this under an hour. So this is going to be quite fast-paced. All the lecture slides are on Canvas. There is a lot of information on those slides. So anything that I don't say, you can go back to the slides and you can look up that information. You can also use your resources to look at some of these concepts. But to remind you, you will also have an SGT class tomorrow. Just give me 1 second. There we go. Can you guys still hear me? Yes? Okay, you'll still have an SGT class tomorrow, which is 2 hours to kind of help you solidify the concepts that we go over today. So the overview for the anatomy practical sessions themselves, you can see that there's only 3 for this module. We have a lecture today, which is the urinary system, the overview of it. You will then go into your AP, your anatomy practicals, or your small group teachings tomorrow, which are 2-hour sessions. And this is the time to kind of solidify the knowledge, to ask any questions, to look at any clinical manifestations or any clinical presentations during your SGT classes, okay? So I recommend that you start looking at the worksheet tonight because there are some, I believe there's some questions to be done before the session because the session will be quite fast-paced tomorrow with your demonstrators and your fellows. You will then have you'll have a renal histology class around October, I believe. Yes, towards the end of October, you'll have a renal histology class. I believe it's a online workshop, online videos, and then you have a workshop to ask those questions. And then the last one that you see is the maintenance of continence. These are going to be case studies that you will be given. You have to then subdivide yourself into groups. So you will just divide yourselves into medical groups. Within your medical groups, you will have 4 cases, and then you have to divide yourself accordingly, and then present those group presentations to the rest of your class during your SGT sessions. You'll be given those cases. I believe you'll be given those cases on Canvas, so it's up to you guys to kind of divide yourselves as you will, prepare those presentations, and then you come in on the 17th of November to give those group presentations to everyone. They shouldn't be any more than 10 minutes, so don't worry too much about them, okay? So to remind you about some of the useful resources that we do have, if I just put the laser pointer up there for you, you can see that there is Gray's Anatomy. This is slightly wrong because there is a new edition. So there is a 5th edition that has quite inclusive language in it. So I do recommend that if you go on Clinical Key, it's the Gray's Anatomy that looks purple or red, and that's the 5th edition and has new vocabulary that is quite inclusive in it. We also recommend Netter's Clinical Anatomy. And for histology, we also recommend Wanketta's Basic Histology. So when you do come to those classes, and if you use this resource during your MTM class, this is a very useful resource over here. We also have Complete Anatomy, and I am aware that some of the codes are not working, but we are in the process of trying to get new codes for this academic year. So hopefully by tomorrow, because some of the activities do involve Complete Anatomy, we'll have those codes for you. I want to remind you of Ackland videos. These will be very important this year because you guys will have your prosectorium spotter exam. Start getting used to seeing prosected specimens, and the best way to do that is to watch videos. Because you don't have that much time in the prosectorium, the next best thing is to not look at diagrams that are beautifully colored, but to look at actual prosected specimens. And the best resource that we have are Ackland videos. So you guys should be able to log in, have been shown how to do so since last year, I hope, okay? Another thing I want to point out is the kidneys and also the reproductive module that you will have will tie into your regional anatomy 1. I know it's been a while, so we're talking about this time last year when you looked at the abdominal, I think you're looking at the abdominal wall and any of the features there, as well as the dig module. So these ones are a good thing to kind of go back to and revise some of these concepts because we will be revisiting them today. So when I talk about peritoneal spaces, I kind of expect you guys to know what they are and where they're located and their function already because you did it in regional anatomy. With renal module and also the reproductive module, well, for renal module mostly will come in handy because I believe you guys had your first regional anatomy lecture today, which kind of explained everything you were doing. And you saw that the regional anatomy for this semester will be about the pelvis. This will tie into the kidneys as well. So in other words, while you're revising for your exams towards December, your regional anatomy 2 and your renal component will overlap, and you'll be able to kind of take knowledge from this module, take knowledge from your regional anatomy module, and hopefully produce or retain some of that knowledge that you did get, okay? So this is what complete anatomy looks like for some of you who have not accessed it, but I hope that everyone has access to complete anatomy. This is what it will look like if you're looking at the renal system or at the urinary system altogether. It helps you to kind of distinguish the levels that it is. It helps you to see where or the course the ureters take, where the bladder might be situated. And complete anatomy also has a feature which I hope you have explored, where it helps you to disarticulate certain features, okay? So in other words, it helps you to explode the features so you can see them separately, you can zoom in, see the internal structures and what they're made of. So I really highly suggest that you do use complete anatomy if you're trying to understand some of the questions that aren't clear after tomorrow. So these are the learning objectives for today. They're taken from Canvas. As you can see, there is one overarching learning objective, and that is to demonstrate an understanding of the functional anatomy and histology of the renal and urinary system. This is what we expect you guys to be able to do at the end of the 17th of November, basically at the end of that AP class. It's just to demonstrate an understanding. So you can see that these two first sub-bullet points, hopefully by the end of tomorrow, you will have an understanding. You don't really have to describe or explain as of yet, but to just understand the anatomy and to understand the relationships of these things will be covered today and tomorrow. And then this last subheading that you see here will be covered during the histology classes, and that covers most of your learning objectives, okay? So these are the examinable learning objectives that we have for you this semester. So we're just going to dive right in because, as I said, there are quite a lot of concepts to go over. Some of these I won't be reading off this PowerPoint because it is available to you on Canvas. So I do suggest that you go back, revisit it, zoom into some of these pictures, and make sure that you understand some of these concepts, okay? They all have citations at the bottom, but most of these images are taken from Gray's unless stated otherwise. So if you look at the overview of the urinary system itself, it consists of the kidneys, the ureters, the bladder, and the urethra. So 4 major organs that we see. And these are located in the posterior abdominal region. And these are said to be at the retroperitoneal aspect of the body. Okay, so if we remember from our regional anatomy, what retroperitoneal structures that we see in the abdomen. And some of these structures are the kidneys and the ureters, or part of the ureters. We'll go through that in a little bit. So what I mean by retroperitoneal structures, can anyone tell me any other structures that we find in the retroperitoneal aspect besides the kidneys, suprarenal glands, and the vessels? Anyone can just shout it out. No one knows what other structures lie in that retroperitoneal aspect. pancreas. I heard the pancreas. I will take it. That is one, okay? So please make sure you're revisiting original anatomy because this was taught around this time last year. So go back to those slides on Canvas and make sure you know that knowledge, okay? What we see over here is a presence of fatty tissue that is there to kind of hold the structures in place, but they're also there to insulate the structures. So this is called periphrenic fat, and it's an adipose tissue. So as you know, adipose tissue is there to help insulate and to protect, and that's what it's doing as we see in the section here. And what direction is this picture taken in? So what plane are we looking at over here? Don't know, shout at once. What plane are we looking at in this first image? A little louder. Separating superior from inferior. Transverse, okay? What's another name for it? We can call it the axial plane or the horizontal plane, depending. So that's what we're seeing over here, and we can start seeing the vessels and the kidneys themselves surrounded by this fat, and also some of the peritoneal structures here. So if we take a look at the kidneys themselves, there are usually, in a healthy individual, in normal anatomy, there should be 2 kidneys located on the lateral side of the vertebral column. One of these kidneys is situated slightly more medially than the other, but we will look into why that is and which kidney it is, okay? Well, it says it on the PowerPoint itself. So the left kidney is slightly longer than the right, and it is closer to that midline. The right kidney, however, is slightly lower, and does anyone know why it's slightly lower? What is on the right-hand side of the body that might be pushing the kidney down more inferiorly? The liver, yeah. So it is the liver. The presence of the liver will push the right kidney more inferiorly than the left kidney, okay? You can see the dimensions of this and also see the information on the slide at a later time. So if we compare the right and left kidney, I've gone ahead and highlighted the things that they share in common. I just forgot to highlight the suprarenal gland. So as you can see from the right and left kidney, if we orientate ourselves, this image over here is showing the anterior view. So this is your left side. If we're looking at someone anteriorly, this will be your left side and this will be the right side. If we then go to the posterior view, looking at someone from the back, swaps around. So that would then be the right kidney, and what we see here is the left kidney. So what we see anteriorly speaking, both of them will share only share the suprarenal gland. When we look at the anterior aspect of the right kidney, for example, we start seeing features like the liver, the second part of the duodenum, the right colic flexure, which means the left side will have the left colic flexure, the spleen, the stomach, and any of those abdominal organs that you should know. When we look at the posterior view, they have a lot more things in common, such as the diaphragm, the transverse abdominis, subcostal nerve. However, that right kidney will only be in close contact or in close relation with the 12th rib. So what I mean by that is this right kidney will only be, its only anatomical relation is that 12th rib, whereas the left one, it is the 11th and 12th rib because that right kidney is located a little bit more inferiorly. Over here is an image just describing what it is that I just showed you, and I believe it is in your worksheets for tomorrow, so please pay attention to this concept over here. This is talking about the anatomical relations of the kidneys to the anterior abdominal organs. So what we see on the left and right hand side are the suprarenal areas. We can see that, for example, that right kidney will have a hepatic area, but the left kidney will not have an hepatic area because that is related to the liver. You can see that the colic area for the right is slightly larger than the colic area for the left because that colic, the right colic flexure, is larger anatomically speaking than the left. Okay, so these are the impressions that are made with from the anterior aspect by these organs. So when we look at the anatomy of the kidney, can anyone tell me what view that we're seeing over here? So what view is this? What plane are we looking at? Coronal. And coronal is there to separate anterior to posterior, correct? So what if I tell you this is separating the left to the right? Sagittal. So kidneys are slightly tricky because of the way they're orientated anatomically speaking, okay? So they have been cut to separate. The left and right will be exactly the same, and that is the view that we're seeing over here. So if you take a look at this outer membranous feature that we see here, and that we see in the schematic diagram, this is the fibrous outer layer. This is where the adipose tissue, that perinephric fat, will be located and surrounding the kidneys themselves, and it's there to help insulate and protect the organ itself. Okay, and then what we then see is the inner medulla, and we start seeing a lot of the features here that are numbered. And this image is especially helpful to help you correlate from the schematic diagram. So what we see are the renal columns, which are basically the continuation of, or the projections of that renal cortex, okay? And that is labeled as number 7. These protrusions, or these further protrusions, will have the vessels. So we're talking about the renal artery, renal vein, and the lymphatic drainage will be located around these, around this area over here of the columns. What we then see in this medial aspect are the renal, are the pyramids of the renal medulla. We can also see minor calyces, or calyx is one, calyces for plural. So we see minor calyx, and these minor calyx continue to form major calyces by basically joining in. So about 2 or 3 minor calyces will converge to form one major callus, okay? And this major callus will then go ahead, so one major callus and another major callus, so we have about 2 or 3 major calluses that will go ahead and converge again to then form the renal pelvis itself. And then that renal pelvis will continue down to form the ureters. So just to repeat that, a couple of minor calluses converge to form major calluses. Those major calluses will converge to form the renal pelvis, and that renal pelvis will continue inferiorly to then form the ureter, or ureters on both sides. So when we take a look at the renal arteries themselves, we will find that the renal arteries are located around L1. What else do we find in L1, or level of L1? If we remember, what else is at the level of L1? Or roughly at that level? I know it's been quite a long day, but if we think about the level of the lower lumbar, if one person can shout it out just a little bit louder. What is one, I guess, intestinal organ that travels that way? I'm hearing transverse colon, okay? So that is around that level of L1, okay? And that is also the transverse plane is usually at that level as well. So when we see, so the renal artery is a branch of the abdominal aorta. I did not put abdominal there, but it's important to know that it is a branch of the abdominal aorta, and it is at the level of L1. It usually divides into an anterior and posterior aspect, and those branches will further divide into smaller branches, and these will be the interlobular arteries and the arcuate arteries, as well as the veins. But we're talking about the arteries right now, but notice how the arteries and the veins follow the same path. Okay, so those arteries will go and supply the aspects of the renal, especially around the pyramids, whereas the veins will go and drain that aspect of that anatomy. The right renal artery is longer than the left. I will tell you why, but this is a concept that you'll be going over tomorrow. But just because it has to travel posteriorly to a certain organ, I'm not going to tell you which one because you'll be going through it tomorrow. It has a longer distance to travel because it goes through passes anteriorly through certain organs. So it's a longer distance compared to the left. When we take a look at the veins and the lymph themselves, like I said, the veins follow the same path as the arteries, as we saw in the last image. However, the veins, or the renal vein, would drain into the IVC, so the inferior vena cava. The left vein is longer than the right because it passes behind the splenic vein and other pancreas, and the body of the pancreas. The same way the right artery was longer because it passes through certain organs. The same concept of the left renal vein will pass through or has a longer path to take to get to the kidney. The left gonodal and the left suprarenal vein will join the left renal vein. Okay. However, this is not true for the right one, whereas the right renal vein passes behind the descending duodenum. So what this means is the left renal vein has more structures to drain from than the right renal vein. And when it comes to the lymph drainage, they will follow a similar path to the veins themselves. However, they will go and drain into the closest node, which will be the aortic node, and that is located around this region. There's a beautiful image on Gray's Anatomy if you guys do want to look at the lymphatic drainage, and the closest node would be the aortic node, located close to the hilum of that kidney. So clinically speaking, we have learned, or we have tried to teach you, that veins will usually pass superficial to the veins will usually pass superficial to the arteries. Okay, so which means that veins are usually on top of the arteries. But you can see in this image that this is not the case all the time. So what we see here is that renal vein that we see, and it passes posteriorly to an artery, and that is a superior mesenteric artery. Clinically speaking, this could be detrimental because if, let's say, there's an abdominal, some kind of abdominal constriction or some kind of vessel that is being blocked, or an aneurysm, for example, where the pressure of the vessel rises, that will mean the vein will become compressed. So if there's any blockages, that will mean there's more pressure from that superior mesenteric artery, meaning that that renal vein will become compressed. If it's compressed, this is called nutcracker syndrome. All right, so if you want to note that down and read a little bit more into it, this is further reading. It's called nutcracker syndrome, and it means there's a deficit of draining from that particular kidney because it's being compressed by that superior mesenteric artery. You can try look at what the patient might suffer, but usually you'll see blood in the urine and a lot of pain around the flank area, so radiating pain around the flank area, and also urine in the blood. Those are some of the symptoms that give you an idea of what kind of clinical presentation that we'll be looking at. All right, so moving on to the nerves themselves. The nervous innervation of the kidneys are both parasympathetic and sympathetic, okay? The innervation of the renosympathetic plexus, and that will Sorry, I thought I had a video to show you guys, but it's not loading. So if we take a look at the parasympathetic nervous innervation, this comes from the vagus nerve, which is CN10. Thank you. Yes, so this comes from this vagus nerve, which is CN10. And as you know, the vagus nerve is responsible for parasympathetic nervous innervation for a lot of the abdominal organs that we see, the esophagus, the stomach, and a lot of the intestinal organs. And this is the same for when it comes to the kidney. So with the vagus nerve itself, with the afferent sensory, so now if we're taking a look at the sensory output from the kidneys, these get transmitted as a sensory up to the spinal column at around level T10 and 11. Okay, so this is sensory output from, let's say, the kidney stone. So this is pain you'll be feeling. And those signals will travel up to the spinal cord at the level of T10 to T11, give or take. Okay, so this is usually field pain or referred pain, and that's usually coming from calcifications such as kidney stones. When you look at the sympathetic trunk as well, you can see that the sympathetic trunk will have a norepinephrine release, which causes vasoconstriction. So the action of this is basically a response to something happening to the kidneys. So let's say the body needs more water or more sodium, more electrolytes. This will feed back to the kidneys, and they will try and reabsorb these things before excreting it as waste and urine. In order to reabsorb this, you need to vasoconstrict these vessels. So to vasoconstrict these vessels, and this is done by a hormone called renin. So the sympathetic norepinephrine will cause the release of renin, which will cause vasoconstriction, which will cause the kidneys to constrict and not to essentially excrete the important water, salts, and sodium and any electrolytes as the body needs it back. This image over here is pretty useful to kind of show you the levels in which some of the nerves that you have seen, hopefully in the prosectorium, the order in which some of these nerves will be emitting from. So you can see that they come in order depending on which one. So if you take a look at the iliohypogastric or even the subcostal nerve, for example, this is the order that you see them in as they transmit through, transmit and pass through the kidneys to go and supply the anterior abdominal walls. Okay, so with the kidneys, hopefully that was the function, and you will be doing a lot of the activities tomorrow to kind of solidify your knowledge, but for now we're just going to move to the ureters. So after the kidneys themselves, there are long tubes that transmit the urine and the waste down to the bladder. So these are just hollow tubes that are there in order to help transport the waste. So these ureters will convey urine to the kidneys, and they're about 20 to 30 centimeters long. They travel from the lateral aspect. If I show you, travel from this lateral aspect, move slightly more medially to the midline to where the bladder is situated in that pelvic cavity. So hopefully when you are doing regional anatomy, when you're looking at the pelvis as a ring, I believe, for this year, you were looking at the pelvis. This will tie into it, especially because the bladder is situated within the pelvic cavity, and also the parts of the ureters are located in parts of that pelvic cavity as well. So the ureters will travel inferiorly down, and as you can see, they start at this junction over here where the hilum is, and so where the hilum is, that is the junction in which the ureter begins after that renal pelvis. If you remember where the minor and major calyces met, formed the renal pelvis into the ureters, and that happens at this uteropelvic junction. So this is a bend that we see, and I'll be asking a little bit more questions about these kinks that we see in the kidneys in a little bit. So the ureters begin at this level, and then they pass from the retroperitoneal aspect, and they move anteriorly to enter the that pelvic brim. And you should know why I've put in the answers here, but you should know the course in which it takes and what kind of structures it will be traveling or passing by or passing nearby or passing via. Are they traveling through certain muscles? Could they be compression there? Are they traveling through certain nerves or any kind of vessels or any kind of arteries? So as you can see, I've kind of highlighted 3 major points, and these are called constriction points, if you remember from, I hope, regional anatomy. These constriction points are essentially a physiological constriction, so physiological bends, or where they come across certain features that can cause anything to be lodged in there. So if we're talking about kidney stones or any calcification that we find in the kidneys, if I just zoom in over there, they can be lodged in those 3 different aspects because of the way the ureters are anatomically formed. So if a calcification is found near the bifurcation of that common iliac vessel, the bifurcation from the internal to external, and that's around the pelvic brim, we call that the mid-urethral obstruction. If you notice that distal calcification down here is the distal urethral obstruction, and then up here at the uteropelvic junction, we see the uteropelvic obstruction. This will cause pain radiating pain around that posterior and anterior aspect of the body. There we go. And that would just cause pain and also blood in urine and just trouble passing urine and passing the waste to dispel it out of the body. If we then take a look at the arteries, veins, lymphs, and nerves of the ureters themselves, I've all put it in one slide because there's not as much detail as, let's say, the kidneys. So if you work through these bullet point by bullet point as I clarify what they mean, with the arteries themselves, we can see that the arteries, the ureters will receive blood from three different aspects or three different branches of the abdominal aorta. So the proximal part, so just about this region here, so the most superior aspect of the ureters will receive renal supply from the renal artery, or receive arterial supply from the renal artery. The middle aspect that we see around here will receive it from your gonadal arteries. So those are your testicular or your ovarian artery, male or female, depending. You will then see the distal aspect just around this, around this area over here, and that is the arterial supply is from the vesical artery, superior vesical artery. When we look at the veins, unfortunately, I couldn't find a better image that would show the same concept, but it is almost the same concept, or that they take the same path as the arteries, but instead of supplying the ureters, the draining from the ureters to go into the IVC. Similar to what we saw in the kidney themselves, we can see that that left renal vein will be draining, from that left renal vein, will be supplying the left kidney, will be draining from the left kidney, and also draining from the gonadal vein, the left phrenic vein, and the left adrenal vein. So that left aspect has a lot more organs and a lot more structures to drain from than the right side of the vein, right side of the body. And then when we look at the lymphs, which follow almost a similar route to the veins themselves, they'll go and drain close to the IVC. The lymphs will drain to the lateral aortic nodes, like I said before, similar to what we saw in the kidney, and that is located at L1. So if you remember where the hilum, so the nodes will be located just around here, and that's where the lymphs will be draining into. Innervation is by the renal, your gonadal veins, and the hypogastric plexus. You will look into where the lumbosacral plexus, you'll be doing an activity tomorrow to really refresh your memory to see where the origin points of these nerves come from. There we go. So moving down from the ureters, like I said, there's not much to say about the ureters except that they are there to help with the excretion of urine, and they're basically hollow tubes that transmit urine from the kidneys, or the waste from the kidneys, to the bladder. So what we want to then concentrate on is one of the main organs, which is the bladder, and this is located within the pelvic cavity. Okay, so as you can see from this image, an empty bladder will be located within the pelvic cavity. However, a full bladder, which holds about 500 milliliters, will rise superiorly and actually overpass the pelvic brim. So it will actually go out of that pelvic cavity to go into the abdominal region when it's a full bladder. So this organ itself, it's able to contract and to expand. And if you remember from your MTM lectures, I know this is asking quite a bit, but if you remember from your MTM lectures from this time last year as well, can anyone remember what kind? I put the answer there. So it's called transitional epithelium. Is there another name for this? So you'll find it, Netter says transitional. I think Grace will call it something different. So we need to know the name for both, just in case you're looking at different resources. As a hint, it is something to do with the urinary system. So this, if people don't really remember, is the urogenital epithelium, okay? Or the transitional epithelium. What it looks like is something like this, but don't worry, you will be going through this in your histology. But what the tissue looks like is layers of basically overstacked layers, which help form a larger surface area, and they are ridged in order to allow the expansion and to hold that much fluid. So remember, if things are layered and things are highly folded, it's because you need to increase the surface area for anything it contains or to hold certain things such as urine. So the fact that this is transitional epithelium helps with the function of the bladder. So looking at this image, which is taken in what plane? if you can look at the anterior and posterior view, so it's splitting it from the anterior and posterior. Coronal. I heard someone whisper it or say it, so it is the coronal view that we're looking at here. So this image is especially good if you can access complete anatomy because you'll be able to see this highly folded rugae or rugae, depending, and you'll also be able to see the function of the trigon. So please make sure that you are going to revisit complete anatomy to just solidify your knowledge on this. But the base of the bladder itself is triangular, okay? So that is a big giveaway to the shape of the bladder. It is in a triangular shape. The inside, which is called the trigon, or what we see over here, this V-shaped trigon over here, has smooth muscle membrane. So again, revisit MTM and see why it being smooth muscle is relevant as opposed to it being transitional epithelium, for example. So this will help you, hopefully, when you go to your histology workshops to kind of explain the function of the bladder because it's smooth muscle and it also has transitional epithelium. So what we see over here at the trigon is the openings of the ureters. So remember, we had this bend and then the ureters will go and open into the bladder, and this is where urine is expelled and it is collected until there is a response, there's a sensory response in order to expel it outside of the body. The bladder is surrounded, if you can see this over here, is called the detrusor muscle. So the detrusor muscle is a smooth muscle and it's there to help with contractile function. So I don't know if you remember last year, I think we came across the detrusor muscle somewhere else in the body, but it's also there, and you'll see it during your reproductive module, but it's there to help with contractile actions. So if you think about the contraction of a bladder, if something is squeezed, that means something is going to be expelled. So when we are about to pass urine, it is the detrusor muscle that helps with the contraction of the bladder to expel the urine. The urine is then expelled from this internal urethral orifice and travels down to the urethra. Okay, this internal urethral orifice, even though I have shown it, it is debatable whether or not it is present in females. So this is extra reading for you guys to do. Is it present in females? Why do people think it's not? Or is it a debatable subject? Again, we have a circular sphincter. So think about the type of circular muscles that we have and the role a sphincter plays. So depending on the shape of that muscle, a sphincter is there to hold and to release anything. So it's there to hold the urine so it doesn't, so you're not just passing urine. So that is incontinence. So it's there to hold the urine until there's a sensory response to expel the urine itself. So moving to the arteries, veins, lymphs, and nerves of the bladder. This image I did myself on Complete Anatomy just to show you that you can go ahead and do it yourself too. So if I zoom into particularly here, this is a female. So we can see that this is the uterus over here, and the uterus sits superior to that bladder. What we're concentrating on is the red and blue, and those are the nerves and the arteries that we see. So with the arteries themselves, they will come from, So with the arteries themselves, they come from a branch of the internal iliac artery, which is a branch of the common iliac artery, which is a branch of the abdominal artery. There are two superior and inferior vesical arteries, both on the right and left-hand side. So these little vessels that we see here are called your vesical arteries. And those are the branches of your internal, which is the branch of the common, which is the branch of the abdominal aorta. When it comes to the veins, so the arteries are supplying while the veins are draining from the bladder to the IVC. So they will follow the opposite path and they'll drain into the internal iliac vein, which then drains into the common iliac vein, which then drains into the inferior vena cava, etc., etc. The lymphatic drainage is to the internal iliac nodes. And I did not include it in this image, but if you go on to Complete Anatomy, do this, render this diagram and then click on lymphs, it will show you that there is a passage of lymphs just around that internal iliac, where we start seeing the bifurcation of the internal and external iliac, and we see some lymphatic nodes, and that's where the drainage will begin, and they'll travel up. The bladder itself is innervated by the autonomic nervous system. It has autonomic nervous system innervation from the inferior hypogastric plexus. So one example I will give you this, I will tell you today, just because of time, we can go on and on about the innervation of the bladder. But what I want to talk to you about is the micturition reflex. So the reflex, micturition means urination, and the reflex is the response to the need to pee, okay? So what we have around here, I'm gonna see if I can pull this video for you. No, it's not gonna work. So when the bladder fills up until it passes that pelvic brim, you will get the urge to urinate. These are your sensory, the sensory innervation, and this will go through the inferior hypogastric, travel up to about T10, T11, give or take, and the response to that is the release of the, the contraction of the detrusor muscle and the relaxation of the sphincter. Okay, so this, so basically what that means is if there is an urge to pee, the response to that will mean that the detrusor muscle will contract and the sphincter will relax. This will mean the contraction of the bladder and the relaxation of the sphincter will mean urine is able to pass through. In males and females, it is very different. We'll look into it when we look at the urethras in a little bit, but take a look at why male and female response for the need to urinate is slightly different. This hopefully is a bit of revision because we are about to move on to the urethras themselves. So what I wanted to show you here is the sagittal view of essentially the lower abdomen and the pelvic area. So we have a male and female over here. What I've circled in red are your pouches. So these are pouches or empty spaces or fluid-filled spaces that are made from the peritoneal foldings, okay? So you can see that in males, we only have one pouch, so one kind of segment where fluid can accumulate, and that is called the rectal vesical pouch. In females, however, because there is the uterus and there is the uterus that is located superiorly, and then we also have the vagina and the rectum, it then forms two pouches. So we've got the uterovesical pouch and the rectouterine pouch. This is important clinically speaking because I said these are just fluid-filled spaces, and this can be a site for infection, especially for, if I have, oh, there we go, especially when it comes to a lot of, females, a lot of the fluid that can accumulate there can cause UTIs. That's why females are more susceptible to UTIs, so urinary tract infections, than males, because there's more chance or more fluid-filled spaces in females compared to males. There is also research that says a lot of the cancers that we find are around the pouches as well, so they accumulate around these pouches, so you can read more into it when it comes to cancer when you do that module. Okay, so this is the last couple last slides, and now we've moved more inferiorly down, and now we're talking about the excretion of urine from the body to outside of the body. Okay, so remember, urine has a lot of waste and byproduct that we're trying to excrete out, and it leaves via the urethra. With this, it's important to be able to distinguish the different anatomical morphology when it comes to males and females with the urethra because they differ a lot. In females, in female anatomy, the urethra is just about 4 centimeters long. However, in male anatomy, it's about, I believe, 20 centimeters long. So you can see the vast difference of it. Because there's a shorter urethra in females than in males, females are more predisposed or more susceptible to infections because of that as well, because it's a shorter canal. So with the urethra, when it comes to females, it will be, when it comes to the arteries themselves, it is supplied by the pudendal and the vaginal arteries. This is different to the male anatomy, which we'll look at in a little bit. The veins will follow a similar path to the arteries, as I explained. So most of the urinary system, veins and arteries will follow the same path, just opposite. So instead of supplying, they are draining from, or instead of draining from, they are supplying. And then we can see that the lymphs themselves will drain into the sacral nodes. So think about where the sacrum is, and then laterally to that, there are nodes where the lymph will drain into and travel up the body. Innervation, when it comes to female anatomy, is from the pudendal nerve and the vesical nerve plexus. I'll explain a little bit about this in a little bit, but you guys should hopefully know where the pudendal nerve is, but I'll show you in the next couple of slides. In male anatomy, like I said, it is much longer, so we can see that the urethra is 20 centimeters long. Unfortunately, that means we need, with the urethra, it has been split into 4 parts, and you need to know what those 4 parts are when it comes to the male anatomy. With the female anatomy, it is quite simple. It is just the urethra, 4 centimeters long. You just need to know the blood, the arteries, the veins, the limbs, and the innervation. However, when it comes to the male anatomy, you need to know the different segments in which this urethra is divided into. This image shows it being color-coded, and you can see that the urethra itself will start from this preprostatic or intramural part of the urethra. And this is where the internal sphincter is located. So when that sphincter relaxes, urine will pass through that preprostatic part, move distally, and it will bypass or travel through the prostate. So we then call this green part, we call it the prostatic part, or the prostatic urethra. You can see that the ejaculatory ducts will merge with the prostatic urethra to travel down. So that means semen and urine sometimes can travel down that same path. What we then see in blue is the intermediate part, which would then form the spongy urethra, which is located deep to the corpus spongiosum. When it comes to, so that's basically what I've explained over here. But when it comes to the arteries and veins that supply, or mostly the arteries that supply the parts of the urethra, they are usually they're usually denoted to the arteries, to the urethra part itself. So you can see that the prostatic part or the urethra part will be supplied by a prostatic branch of the inferior vesicle. The same will apply to, let's say, the preprostatic part will be supplied by a preprostatic branch of the inferior vesicle, okay? So mostly the parts of the names will correlate to the artery branches themselves, so it's a little bit easier to remember. And then when it comes to the veins themselves, the same applies, and these will then go and drain into the prostatic venous plexus, will then go and drain eventually into the IVC. The lymphatics comes from the spongy urethra to the deep inguinal node. So if we think about what the inguinal region is, where the inguinal canal is, that is the part we're talking about. So just around where the pelvic brim is, where that iliac crest is, that's around where we'll start finding those deep inguinal rings located deep to that pelvic brim or that iliac crest. And the innervation comes from the prostatic nervous plexus. So with the nerves, it's important to know what types of plexi or plexuses we do have, because what we mean by nerves, it's an accumulation of small little branches that are coming from a major nerve. So try trace back where these small nervous plexi are coming from and what that major branch is. So just to conclude everything, I know it was a lot of information, so I have included a glossary of some of the key terms that you may not have come across that you should know or start to get used to knowing that terminology. You can go ahead and add more terminology to this tomorrow because there is going to be more terminology. You will be able to revise a lot of these concepts again tomorrow, so please read those worksheets that we have provided for you, do the pre-session things, and then go into the sessions with questions ready. And just to remind you, these are the resources available to you, and you also have 3D rendered images on Blue Link if you want to access those as well. Thank you, everyone. I am going to put the code back on. Hopefully it'll load for you. For those of you who haven't taken attendance, now's your time to do so. There it is. Okay, wait, just give me one time. I'm just going to pause the recording.